one more on this panel. So next up is Lydia Sochan. She is a third-year biochemistry student at the University of Western Ontario. Lydia has done clinical work with children at the University of Washington Autism Center and research in brain aging through the OwenLab at UWO. She loves to combine her knowledge of the biological sciences with psychology, and she has a particular fascination for the biological factors involved in the etiology and maintenance of conditions such as anorexia and autism. Here is Lydia's presentation from childhood abuse to anorexia nervosa, the role of aberrant stress signaling, dissociation, and emotional avoidance.
Hi, everyone. As it was mentioned, I'm Lydia. My subject is the relationship between childhood abuse and anorexia nervosa. In particular, I'm investigating which factors could potentially mediate this relationship. So to characterize my subject a little bit, anorexia nervosa is characterized by an extremely high mortality, one that is higher than any observed in any other psychiatric disorder, extremely low motivation to change, and extremely low recovery rate. Given these factors, it is particularly important, and I cannot highlight enough, the importance of investigating the etiology of the disorder in order for us to develop our understanding of what factors promote and maintain the disorder so that we can allow individuals to recover. Previous research into the etiology of anorexia has traditionally focused on sociocultural factors such as sexism or the female body ideal, as well as personality factors such as neuroticism or perfectionism. But another subject that I think is worthy of investigation is childhood maltreatment, so abuse or neglect by caregivers. In particular, to highlight why I think it is worthy of investigation, I'd like to share a statistic with you. A recent study found that among those with a diagnosis of anorexia nervosa, 21% had experienced emotional abuse during childhood and 66% had experienced emotional neglect. Given these absolutely stunning statistics, I don't think I need to tell you that it's worth investigating as to whether this is a potential cause of anorexia and how it may potentially be related to anorexia development later in life. So the first mechanism that has been investigated as a possible cause of anorexia nervosa is HPA dysregulation. On the left-hand side, I've included a diagram which shows the HPA axis. In response to stress, the hypothalamus secretes hormones to stimulate the anterior pituitary gland, which in turn stimulates the adrenal cortex, which secretes cortisol, which is stress hormone. So essentially what I'm saying is that in response to stress, the HPA axis causes cortisol, which is stress hormone, to be secreted. Now, it's been found that HPA dysregulation is related to both anorexia nervosa as well as childhood maltreatment. For instance, a study in 2015 found that in all eating disorder patients, there was dysregulation of the HPA axis, but in particular, there were actually in-group differences among different anorexic patients. Those with a maltreatment history among the anorexics showed a blunted cortisol response as compared to those who did not have a history of maltreatment during childhood. And a later study in 2018 by the same authors found that in response to the Trier social test, which is essentially a situation which is designed to induce stress in participants, all of the anorexic participants showed an increase in cortisol, so increase in stress following the test, but that those who had a history of childhood maltreatment showed a blunted response. So combining the findings of those last two studies what we can see is that it appears that within those who experience both anorexia nervosa and childhood maltreatment, there seems to be both a lower level of basal cortisol level, so the baseline level, as well as lower stress reactivity of the HPA axis. But why do we observe this finding? Why is it that those who have experienced childhood maltreatment show HPA axis dysregulation? Well, allostatic theory posits that our stress systems focus in proportion to the environment. So those who experience early childhood maltreatment have experienced very high levels of stress in the environment from a young age. And so in proportion to the stressful environment, their HPA axis decreases their reactivity to such stressful situations. So far I have outlined that HPA axis dysregulation occurs among those with childhood maltreatment, anorexia nervosa, and also that it may be that childhood maltreatment plays a causal role in HPA dysregulation due to allostatic theory. But what is the potential role that HPA dysregulation may play in anorexia nervosa? Well, it was found in a study by Lawson et al. In 2013 that both active and weight-recovered anorexia patients showed a negative association between HPA axis dysregulation and subjective appetite and food motivation, meaning that as their HPA axis became more dysregulated, they were less motivated to eat and experienced less appetite. Moreover, in response to dysregulation, they would experience lower premeal activation in relevant brain areas, highlighting that it appears that HPA dysregulation may promote restrictive eating behavior, such as that observed in anorexia nervosa. Another possible mechanism is via the dopamine system. It is well established in the literature that altered dopaminergic reward system signaling is a factor which is involved in the pathophysiology of anorexia nervosa. But something which perhaps has been less noticed by the literature is that dopaminergic reward circuits are modulated by the HPA axis. And so it is possible that it is due to dysregulation of the HPA axis that we observe this faulty dopaminergic reward system signaling within those with anorexia nervosa. Next, I'd like to highlight cognitive mechanisms by which childhood abuse could promote anorexia nervosa. So in this case, I'll be talking about dissociation and emotion avoidance. Before I can do that, I need to define a particular phenomenon that is little known, but actually occurs in quite a few cases of those with anorexia nervosa, and this is called eating disorder voice. Eating disorder voice is when someone with an eating disorder has a voice in their head which tells them comments on their eating or their weight, and it's perceived as internally generated, so not quite a hallucination, but it is perceived as being distinct from oneself or from your own thoughts. And it's estimated that the eating disorder voice can occurs in as many as 96% of cases of anorexia nervosa. And it is well established that critical eating disorder voices are associated with greater severity of eating disorder symptoms, longer duration of illness, lower self-esteem. Essentially, the anorexia that one experiences is more severe as the eating disorder voice is more critical. Now, what's also interesting is that eating disorder voice generation is thought to arise due to trauma dissociation. And this trauma dissociation model of voice hearing was proposed by Longden et al. 2001. in this case, someone who experiences childhood abuse dissociates from the content of such abuse, for instance, critical comments made by abusive caregivers. And later in life, these critical comments return to the psyche in the form of voices that are perceived to be separate from one's own thoughts. And so in the case of eating disorder voice, it's thought that the eating disorder voice may mirror the personality of abusive caregivers early in life. And then, in addition to that, what's even more interesting is that the relationship between childhood emotional abuse and the development of an eating disorder voice is mediated by dissociation. And of course, this model of voice hearing that I was talking about, the trauma dissociation model, proposes that it's due to dissociative processes that the cognitive content of emotional abuse is transferred to the eating disorder voice. It's also interesting because since the beginning of studies into anorexia nervosa, the illness has been conceptualized as a form of dissociation or emotional avoidance. And qualitative studies have shown that anorexics often perceive one of the functions of their illness as being to avoid emotions. So it's possible that emotional avoidance and dissociation are sought in response to childhood emotional abuse, and that this emotional avoidance and dissociation is in turn related to the eating disorder voice, which is experienced as a symptom of anorexia nervosa. So, in conclusion, the rate of childhood abuse, especially childhood emotional abuse, is unprecedented among anorexics and truly shocking. So it's definitely plausible to suggest that there must be some relation here between childhood abuse and the later development of anorexia nervosa during adolescence or during early adulthood. And two possible mechanisms have been explored through the course of this presentation. The first is HPA dysregulation, which alters the reaction to stress. And the second was via dissociation and emotion avoidance, which are related to the eating disorder voice symptomatology of anorexia nervosa. But I'd like to highlight before finishing my presentation that the research that I've presented so far has been correlational, and really this research that I'm presenting is very preliminary. There aren't a great number of studies on these phenomena that I'm presenting to you. So I'd like you to take all of the conclusions that I've said with a grain of salt, with still realizing that as the field develops and more research occurs, it is likely that these conclusions will be built upon, perhaps rejected as we come to understand that there are more complex phenomena at play than even we realize right now. But I think what my presentation highlights is that these are very interesting clinical phenomena that are worthy of investigation in order to investigate the plausibility of a model linking these factors. Thank you.
Thank you so much, Lydia. That was a great presentation. So now we have time for some questions. So I'll open up the floor. You can either unmute your mic and ask a question on your own, or you can type it into the Q&A for our panel and have one of us ask it out for you. So I'll give just a quick minute, and if anyone wants to ask something, they can go right ahead.
Yeah, we are hopefully having Sharpen the Quill for the fall. So especially Lydia's paper. I think that would make an interesting article in one of the student journals. And I think you should pursue it and put some thing. Also, the Southeast Asian mental health maybe focus on females, rather try to focus more down, more specific, and again, maybe consider signing up for Sharpen the Quill in the fall.
Planning on definitely applying again.
Yeah, I definitely want to do it in the fall as well.
Good. Well, I'll ask a question. So I'll ask one to Belinda because we haven't heard from her in a while. So one of the things that you had said is that in order to do self-care, you need to, or you posited this idea of self-efficacy, where I'm the one who can acquire my goals. But in order to do that, you need some sort of intrinsic motivation. And I was just wondering if you could expand a little bit on what that might mean and how one could gather intrinsic motivation if they are a procrastinator who is lacking in it.
Thanks, Zach. That's a good question. I feel like to a certain extent, like you might not necessarily need an intrinsic motivator. Like, prior to, at least for myself, like before I got into uni, like I was very much the type to be like, I'm gonna get it done, but only for the sake of getting it done, so that like I won't get chased for it. But like in terms of like getting an intrinsic motivator, it might be like a bigger reason. So for example, like when people like create a business, like people create businesses for all sorts of reasons, but they might like, if they're not thinking long term, like say like I want to make this like a family legacy and this business is going to go on for like generations to come, they might be like, oh, this is just a short term thing and I can give up whenever I want. In order to think the long term, like you might need like a bigger reason. So for example, like some people might want to use the business to retire their parents, have a sufficient amount of income to like quit their 9 to 5. So in terms of finding an intrinsic motivator, I think you should, what I would do is like I would ask questions to myself and kind of be like, okay, why am I doing this? And what's like how am how is it helping me and how am I using it to help other people? So for example, this internship, writing books. So one, I'm learning the knowledge myself, but I'm also giving back by writing the books and like for people to read and to help other people that way. So I guess that's my answer. I'm not sure if I'm not sure if you want me to elaborate on anything else, but yeah.
Thank you very much. No, that was a great answer. I'll see. Does anyone else have a question?
I have a question for all of the panelists. So we're talking about discussions and research in mental health or the realm of it. That's a pretty contemporary and upcoming research section. So a lot of the limitations is or are just lack of statistics and studies and experimentals and all of that. But with it, we also see a lot of pseudoscience, misinformation, negative stigmas, or I think misinformation is a huge part of it with the pop culture, trends in self-care and posy vibes only and that kind of a thing. So I'm kind of wondering how each of you feel we could work on overcoming those negative stigmas, misinformation, pseudoscience that hasn't been properly argued against.
So to add another perspective onto this complex issue of stigma, when we're talking about a subject like mental illness, there's many different ways in which we can conceptualize mental illness. And one of the ways in which we can conceptualize mental illness is called the medical model. So the medical model of mental illness is when we think of a mental illness as being the same as a physical illness, essentially, as being an illness and not an extension of someone's personality. Now, of course, the medical model has its faults and its limitations. I do not want to say that it is the best model or a model that should always be used. But what I do think is valuable about the medical model is that it takes blame away from the individual. And I think the thing about stigma and mental illness is that stigma is not the same for every mental illness, and for mental illnesses that have very overt behaviors that seem to be the choice of the individual. For instance, I'm thinking of addictions or anorexia, where it seems as though the individual is choosing to engage in a behavior. Stigma can be quite severe for these illnesses. But if we conceptualize those illnesses by a medical model, we understand that it's not an individual choosing to engage in those behaviors. It's an individual with an illness that makes it so that it is more difficult not to engage in the behaviors than to engage in them.
Thank you. Those were all very, very good answers.
Thank you.